Hello friends, welcome to the session of Academy of Carnivals, me and my hysteroscope. We know hysteroscope is an amazing instrument. I feel hysteroscope is the feminine instrument. It just adjusts the curves of the uterus. So, in the cavity, when we enter, me and my hysteroscope always talk together. Is this a normal endometrium? Oh, that looks like a septum. I can deal with Caesar. Occasionally, monopolar, bipolar. See, this is a surprise polyp. Can be managed with scissors, forceps or laser. Myoma, a tough challenge. Adhesions, ismocele, retained products of conception, abnormal uterine bleeding, bad obstetric history, infertility. Friends, just try hysteroscopy for rewarding results. Before starting the session, we must pay respect and thankful to modern technology and all innovations in hysteroscopy. Namaskar. Dear hyster lovers, today we are going to discuss secrets of hysteroscopy from the man behind the machine, that is Dr. Sergio Haimovich. You know, some hands are having affectionate and academic touch. They know philosophy of uterus also and work with compassionate heart. And here comes the ever smiling and affectionate personality, Dr. Sergio Haimovich. You know, his password is just smile. And with his $1 million smile, he can face any situation and any tough surgery. He is head of hysteroscopy unit, Del Mar University Hospital, Barcelona, Spain. He is one of the main organizers of Global Congress on Hysteroscopy in Barcelona since 2017. Welcome, Dr. Sergio, to the world of hysteroscope. I know you are very much skilled in office hysteroscopy, and I have witnessed your patient comes with smile, gives smile to your smiling face, the hysteroscopy done with the smile, and the patient goes with a smile. Can you please tell us the secrets of your office hysteroscopy?
Dear Sushma, I will answer now to the questions you asked me to answer. The first, you are asking me, please tell your tricks in office hysteroscopy. There are many tricks you may learn in office hysteroscopy. I think the first one and most important one is, most of the gynecologists that perform hysteroscopy, they sit down in front of their patients and they perform hysteroscopy sitting down. When you ask them, why do you sit down? No one has an answer. Usually they say that that's the way they were taught, and they used to do it that way. So I believe that when you're sitting down, like I'm sitting right now, and you take in your hand the scope, it means that you sit in 90 degrees, with the arm in 90 degrees, holding the scope in your hand. It means that you start using your biceps, your pectoralis and your delta. It means that you use muscles whenever you move, performing the hysteroscopy. But if you stand up like I do, it means like that when you stand up, you just hold the scope in your hand. It means that any movement you do, it's with the hand. The movements are becoming more smooth, very precise movements, no strength. And when you work in office without anesthesia, this is very important. I think it may be the most important trick. Then, if you work without anesthesia, you must understand that the patients come first, and you must worry about what she feels, the discomfort she's feeling. So standing up is one of the things we do. And then you have to work with low pressure. You need to think about distraction. And distraction means someone talking to the patient, letting letting the patient to choose the music she likes. I have a lot of Muslims coming to the center, and they choose praise from the Quran, and they like, they are inside that, and they pray together without they hear, and it's a distraction. So when you are distracted, you are less centered, focused on what I am doing, it's easier to perform. So this is the answers of some of my tricks to office hysteroscopy.
Thank you, Dr. Sergio. You rightly said about the distraction of the patient. And I still remember when I was in operation room with you in Barcelona, you told me in the beginning only that patient is the boss and you should listen to your patient. So be compassionate and friendly with your patient while doing office hysteroscopy. Dr. Sergio, you are director, founder of International School of Lasers in Gynecology. And you have done a lot of work on lasers. Can you please tell something regarding the laser surgeries?
Well, I will tell you a small story. How I started with the laser. I am the first one in 2007 that started to perform intrauterine surgery with laser. How did that arrive to me? So one of our distributors of devices, he told me, listen, I have this small laser device. I'll bring it to you. I know that you are performing hysteroscopy. Look, what can you do with that? He brought me some fiber, because you use a fiber that goes to the working channel, and it was a thin fiber, very flexible. And I saw that with that fiber I could cut polyps, no more. And then I asked him, listen, I need a different kind of fiber. I described the fiber. He brought me that fiber, and since that moment I started to develop many surgical techniques to do myomas, to do septums, dysmorphic uterus, everything with laser. What is the good thing about laser in office? The best thing is that when you work in office, you don't want pain. And if you work with electricity, like bipolar, and you are in the wall of the patient, the electricity goes to the myometrium. The myometrium, there's a lot of innervation, and the patient feel that, and you have to work with low intensity in order to lower the discomfort. When you work with the laser, the dispersion of the heat, because laser is light, is heat, is between 0.5 to 1 mm. Patients never feel that. And another good thing about the laser is that the wavelength we use, light wavelengths, we use doing hysteroscopy is 1470. This wavelength has both affinity to water and to hemoglobin. What does it mean? It means that I can cut and even vaporize, because it has affinity to water. But at the same time, simultaneously, I can coagulate due to the affinity to the hemoglobin. And that's a good thing about the laser, that there is no other device that has these characteristics.
Yes, I have witnessed it. Now coming to next question, that we all know that endometrial polyps are very common in our practice. So how to tackle these endometrial polyps with the help of lasers? And I know that you are very fast in laser surgeries. What is the operating time with the help of laser for these polyps?
With laser. Really, endometrial polyps is the most frequent pathology we meet in hysteroscopy and also in office hysteroscopy. And the laser is very fast. What we do, we just only cut the base, the implantation base of the polyp to the wall. The laser cut is very fast, really fast, no bleeding because coagulates at the same time, and we just free the polyp from the wall, and then we take it out with a simple grasper. The technique is very simple. Can you tell us operating time required for polypectomy? I will add a video in real time, not edited video, and you will see that cutting a normal polyp, it's 1.5 centimeter, it will take 1 minute. It's really fast. Usually, when the polyps are very small, we don't use the laser. And in my PhD, when I published my PhD, I did it on the use of laser in office hysteroscopy. And regarding to the polyps, when the polyps were till 1 centimeter, we always perform it with scissors and grasper. You don't need anything else. When they are over 2 centimeters big polyps, we use the laser. Why? Because big polyps, if you do it with scissors, requires a lot of time, they will bleed. And office procedure, one of the things you must remember, office procedure must be very short. When we say short, 15 to 20 minutes. Why? Because what our patients feel during office hysteroscopy is the distension of the uterus due to the installation of the cell line. And it reminds them, and it's similar to what they feel during a menstruation. The same, instead of cell line, there is blood inside the uterus, so there are small contractions, cramps, and that's what they feel. But after 15, 20, some patients 30 minutes, it becomes pain. And we don't want to cross the line from discomfort to pain. That's why procedure must be short. And 2 centimeters polyp, if you do it with scissors, it might be long. So when we do it with laser, it becomes a short procedure. That's why we do always 2 centimeters or more with laser. Between 1 and 2 centimeters, usually we start with the scissors. And sometimes, especially in postmenopausal women in which the tissue is fibrotic and it's difficult to cut it with the scissors, in those patients, in order to shorten the time of the procedure, sometimes we use the laser. That's about the laser and time of the procedure.
Can you please show us the video? Perfect video technique. Now we'll move towards the father of polyp, that is submucous myoma. And we all know that to operate a submucous myoma requires a lot of skill. So how to deal with these submucous myomas with lasers?
Okay, I will tell you. Submucosal myoma, we have 3 different types. Type 0. Type 0 is when the myoma is completely inside the cavity. There is only a small pedicle that attaches the myoma to the uterine wall. It's this pedicle that supplies blood to the whole myoma. This is G0. G1 is when most of the myoma, it means more than 50%, is inside the cavity, and only a small part, less than 50, it's still intramural, inside the wall. In type 2, most difficult myomas, most of the myoma is inside the wall, intramural, and just a small part, less than 50% inside the wall. Those are the challenging and most difficult. How we do it with G0? Very easy. Always take a biopsy, because you need some tissue for histology to confirm that this is a myoma. It will be a myoma, don't worry. And then it's a G0. You cut the pedicle and you finish surgery. It's a few minutes. You cut the pedicle, we do it with the laser. and you finish your procedure. You leave the myoma inside the cavity. The myoma, if you perform an ultrasound 2 months after follow-up ultrasound, you'll see 100% of them disappear. We published that 5 years ago. What happened with G1? It means that most of it is inside the cavity, but the small part is still inside the wall. What there is between the wall, the myometrium, the myoma, there is a space called pseudocapsule. The pseudocapsule is a space with many connective tissue fibers, very lax, that all of they anchor the myoma to the wall. Also, the blood supply for the myoma comes through small blood vessels that they cross this space from the myometrium into the myoma, and they supply the blood. So what we do, we open the endometrium with laser. Why with laser? Because there is very small damage, but especially there is no bleeding when you cut with the laser. So we cut a crown around the myoma, and then we go between the myoma and the myometrium looking for this plane, the pseudocapsule plane. The moment you are in this plane, with the grasper or small scissors, you perform a dissection. Now I want you to think about not hysteroscopy, laparoscopy myomectomy, or open myomectomy, laparotomic myomectomy. What do we do in these cases? We always look for this plane, the dissection plane. During an open myomectomy, usually with the finger, you can separate the myoma from the wall. During laparoscopy, again, with some kind of grasper, you do a dissection. You pull and you separate the myoma using this cleavage plane, the pseudocapsule. So the same we do during laparoscopy, a laparotomic myomectomy, we do during hysteroscopy. We look for that plane and we make a dissection of the myoma, and the myoma falls into the cavity.
Very nicely explained. But still, G2 myomas are difficult. Do we require two-step technique?
What happened with G2 myoma? This is the more difficult myoma because most of it is still intramural. Sometimes you need 2 steps in order to perform this kind of procedure. But again, you cut with the laser around the crown, cutting the mucosa, and going to find the pseudocapsule plane. The moment you have that plane, you find the dissection plane. Again, you make a dissection with the grasper, and you will see at the same moment that the myoma slowly becomes endocavitarian, slowly migrates into the cavity. And a G2 myoma, when you come to the second step, becomes a G1 myoma, and it's easier to finish the enucleation in office. We're always in office without anesthesia.
Now tell us something regarding office preparation of partially intramural myomas, that is Opium Technique.
In 2009, Stefano Betocchi published his Opium Technique. Opium, it means office preparation of partially intramural myomas. And what he did it with the Versa point. He cut in office this crown, and he saw that the myoma was migrating into the cavity. And in the second step, he sent all the myoma to OR to perform the normal resectoscopy with the bipolar or monopolar resectoscope. He did it with myomas with a mean size of 29 millimeters. No small, it's big. And success rate of his technique was 93%. I saw that technique in 2009, and since then I tried, and I saw and I confirmed that this is possible and feasible to do both steps in office. The only limitation is in size. When the myoma is bigger than the cavity, you cannot perform the enucleation. That's why with myomas of 3 or more centimeters, this technique in office is not recommended. Okay, let's see next question.
Really wonderful. You explained the exact technique. Now, Dr. Sergio, I have seen that in your talks, you have always mentioned about the contents to container ratio. What is that? Can you explain it?
It's easy to explain. All the classifications that they deal with the myoma, G1, G2, G0, even the State W classifications published by LASMAR, they all deal with characteristics related to the myoma. How big it is, in which wall it is, how deep inside the wall it is. All the characteristics are regarding the myoma. But there is another important factor when we perform surgery. It's not only the size of the tumor, but also the size of the cavity. Imagine a 2 centimeter myoma inside a nulliparous uterus, and the same 2 centimeter myoma inside a multiparous uterus. It's far more difficult to perform the surgery in the small uterus of a nulliparous woman. It means that there is an importance here in the relation between the container, the room, the cavity, and the contents, the table you put inside the room, or the myoma inside the cavity. So everything is relative. The best way to understand that is if you have 2 multiplied by 2 square 4 square meter room, 2 multiplied by 2 to put a 2 meters table is going to be difficult, but if the room was 2 multiplied by 3, it's easier to introduce that table inside the room. The same way is when you think about surgery inside the cavity. Think about the size of the cavity also, and that is a ratio. We call it the ratio factor, or the container content factor, regarding the myoma. Think about the cavity also, not only about the myoma.
Very nicely explained. Really, Dr. Sergio, we are very happy for getting wonderful inputs on office hysteroscopy and lasers in hysteroscopy. Now lastly, what is your message to hysto lovers?
Okay, hyster lovers. I think hysteroscopy has been passing through a change in the last years, and today we perform complex endocavitary surgery. So what's coming now? There is hysteroscopy, that's the action of going inside the uterus and assessing the cavity, like cystoscopy for the urologist. And this is something that the same as all the urologists they know how to perform a cystoscopy. This is something that all the gynecologists should know how to perform. An hysteroscopy must be a tool in the hands of all of the gynecologists. Today, being a surgeon of the uterine cavity requires many skills. Today, the procedures become very complex, and you need to develop high skills in order to perform surgery of the uterine cavity. And that's the future, guys. That's my message. I hope that many of you will follow us in global community on hysteroscopy. We started some days ago and become very big with many members around the world, many hyster lovers, and it's growing every day. We're doing research, we're publishing many studies. Almost every month there is a publication from us in important journals, and we are showing that hysteroscopy it's no more the ugly sister of the laparoscopy in the gynecology endoscopy. Thank you very much.
So, we end here with a famous saying by Dr. Carver: start where you are, with what you have, make something of it. Never be satisfied. Thank you